Okay, let's jump right in. If you've ever thought of osteoporosis as simply thin bones that orthopedists deal with, well, prepare for a rigorous conceptual shift. Today, we are completely reframing osteoporosis in this explainer, moving it from a simple structural issue to a highly complex systemic endocrine disorder. We're going to cover the exact pathophysiology, comprehensive diagnostics, and advanced pharmacology without omitting a single clinical detail. So, let's get started.
To ensure a lossless transformation of this vast topic, we'll follow a strict clinical arc, starting with conceptualizing clinical bone strength, moving through epidemiology, secondary causes, diagnostics, supportive pharmacotherapy, and finally, advanced therapeutics.
Section 1. Conceptualizing clinical bone strength and why we have to move way beyond the archaic idea of simply low bone mass.
Here is the crucial takeaway right out of the gate. Osteoporosis is a systemic failure of bone strength. If we anchor to the Endocrine Society of India's precise definition, we have to view bone strength as a composite of both quality and quantity. While microarchitectural quality is definitely disrupted, it's the profound loss of trabecular quantity, which is where remodeling turnover is at its highest, that predominantly drives this disease.
And this perfectly illustrates the paradigm shift. We must separate purely mechanical orthopedic diseases from osteoporosis. While conditions like osteopetrosis or cleidocranial dysplasia belong strictly in the orthopedic realm, osteoporosis, it's fundamentally an endocrine disorder. It is a systemic metabolic failure. Sure, it's often initially heralded by insidious back pain, but it is ultimately defined by its clinical hallmark, fragility fractures, particularly of the hip, vertebrae, or Colles fractures of the wrist. In fact, for a lot of patients, a sudden, devastating fracture is the very first time they even realize they're afflicted.
Now, all mass loss dictates the overall disease burden. The underlying bone quality defect cannot be ignored. It's driven by 5 distinct components: turnover, microarchitecture, mineralization, microfracture, and overall bone and mineral composition, the whole shebang. But of these 5, microarchitectural disruption is overwhelmingly the primary culprit, compromising the structural integrity of the bone.
Moving right along to Section 2, Epidemiology and Risk Factors. Let's break down the exact clinical phenotypes that flag this silent disease. What's really fascinating here is the mechanism of how estrogen loss literally disinhibits osteoclasts, leading to classical phenotypes like the 47-year-old menopausal woman. Because menopause often hits earlier than many assume, vulnerable females can become highly symptomatic by their early 50s. But, and this is critical, you must also actively look for the often missed male patient. Picture a guy suffering a disproportionate distal forearm fracture from trivial trauma, like simply clenching a fist. No way that should break a healthy bone, right? Beyond biological sex and family history, remember this one absolute fact. Smoking is the single most important practical lifestyle risk factor, overshadowing even alcoholism or chronically low vitamin D and calcium intake. Because osteoporosis is an endocrine failure, we've got to relentlessly rule out secondary etiologies. So, let's dive into Section 3, Secondary Causes and Drugs. Taking a close look at the pharmacology, a PhD-level medication review has to capture way more than just the obvious steroids. Look closely at diabetes agents, specifically pioglitazone and other TZDs. We also have to heavily flag proton pump inhibitors. They're famously linked not just to osteoporosis, but to hypomagnesemia and chronic tubulointerstitial disease. Do not overlook lithium with its nasty multi-endocrine complications like primary hyperparathyroidism, nephrogenic diabetes insipidus, and thyroid issues. Also, meticulously screen for long-term heparin, aluminium exposure, excessive thyroxine, anticonvulsants. Oh, and note that for immunosuppressants, cyclosporin is significantly more implicated than tacrolimus.
We also have a massive taxonomy of systemic causes you need to have memorized. Rheumatologic conditions like RA, ankylosing spondylitis, and sarcoidosis are major drivers. And never forget the gastrointestinal link. It's perfectly illustrated by the classic anecdote of a young student with completely undiagnosed celiac disease who fractured a bone simply by bumping their leg against a hostile door. Just incredible. From gonadal issues like hyperprolactinemia, Turner and Klinefelter syndromes, to major endocrine culprits like Cushing's, hyperparathyroidism, diabetes, acromegaly, and thyrotoxicosis, your screening just has to be relentless. Finally, ensure you evaluate for inherited and hematologic disorders, including porphyria, hemochromatosis, Marfan, homocystinuria, sickle cell, and hemophilia.
All right, let's move to Section 4, Diagnostics and DEXA Interpretation, and see how this builds our clinical action plan.
To accurately interpret a DEXA scan, we must detail the critical shift in our diagnostic frameworks. You really have to understand why comparing patients to peak 25 to 30-year-old healthy bone strength via the T-score strictly outclasses the obsolete Z-score. I mean, the Z-score merely matches the patient to others of the same age, race, and sex, which, if you think about it, is practically useless if the entire demographic cohort already has degrading bone mass. We need to know exactly how much structural integrity the patient has lost compared to peak human bone strength.
And here is the threshold. A T-score of less than or equal to -2.5 officially confirms osteoporosis. Now, a quick, almost elementary reminder on the math of negative numbers because it trips people up. -2.6 is indeed less than -2.5, meaning it qualifies as frank osteoporosis. A score between -1 and -2.5 indicates osteopenia. Crucially, though, if you add a fragility fracture to a score of -2.5 or less, you reclassify the diagnosis entirely to severe osteoporosis.
So, when deciding who to screen, textbook guidelines will tell you females over 65 and males over 70. But practical, advanced clinical judgment dictates screening anyone over 50 with pain, fractures, or specific risk factors, or really, even asymptomatic individuals over 60. We now use the FRAX risk assessment tool and even AI-extracted trabecular bone scores to enhance precision. Furthermore, I want to emphasize the limited value of routine X-rays and normal electrolytes. Serum electrolytes, usually totally normal in these patients. And for an X-ray, it literally takes a massive 30 to 40% bone mass loss before radiographic changes even become visible. By the time you see the classic exaggerated biconcavity known as codfish spine or fish mouth vertebrae on an X-ray, a sign also seen in osteomalacia and hyperparathyroidism, the structural failure is already devastatingly severe.
Now that we've diagnosed the microarchitectural failure, we must initiate a highly structured, tiered management strategy. Let's explore Section 5, Supportive and Definitive Pharmacotherapy.
Definitive treatment is explicitly triggered by 3 specific clinical scenarios. Number 1, frank osteoporosis on a DEXA scan. Number 2, osteopenia combined with a fragility fracture. Or number 3, osteopenia combined with a high FRAX risk score. If your patient meets any of these, pharmacological treatment is absolutely mandatory. But before starting complex drugs, every patient universally requires a supportive baseline. This means immediate smoking cessation first and foremost, followed by physical activity, precisely 800 international units of vitamin D3 and 1,200 milligrams of calcium.
To utilize our first-line anti-resorptives, the bisphosphonates, you must drill patients on this exact 4-step protocol. 1. Take it in the morning. 2. Use a full glass of water. 3. Take it 30 minutes before the first meal. And 4. Remain strictly upright for the next 30 minutes. Why this intense, military-style regimen? Because if you fail to instruct them properly, they are at massive risk for esophagitis, which is the most highly tested and clinically common adverse effect of these drugs.
Carefully map out the anti-resorptive hierarchy. We highly prefer oral alendronate as the practical first-line choice, with risodronate or ibandronate as oral alternatives. However, if oral compliance fails or is just unfeasible, we seamlessly pivot to utilizing yearly intravenous zoledronate. Now, while these drugs are life-changing, you must rigorously monitor for rare but dangerous complications like avascular necrosis of the mandible, atypical or collapsing femoral shaft fractures, and hypocalcemia. And critically, you must strictly adhere to the contraindication. Never administer bisphosphonates if the patient's GFR is below 30.
But what happens when first-line therapies aren't enough? Section 6, Advanced and Emerging Therapeutics.
When anti-resorptives yield an inadequate response, the endocrinologist must escalate. You can sequentially step up by using denosumab as a potent add-on anti-resorptive option. Or you can pivot entirely away from anti-resorptives, which, remember, primarily just stop bone loss, to true anabolic agents, the bone formers, drugs like teriparatide and abaloparatide. These remarkable drugs ingeniously leverage an intermittent small-dose PTH effect to actively construct brand new bone, fundamentally altering the patient's microarchitectural landscape.
As an advanced clinician, it is equally critical to know what not to use. Firmly dismiss these outdated therapies from your mind. Estrogen and hormone replacement therapy are rejected due to severe risks of breast cancer, CAD, and stroke. They are now strictly only indicated for severe hot flushes.
Raloxifene, a selective estrogen receptor modulator that acts as an antagonist at the breast and blood vessels, carries way too high a risk for DVTs and hot flushes, despite successfully avoiding the endometrial malignancy risk we see with tamoxifen. Calcitonin, dismissed as a remarkably weak anti-resorptive with zero effect on nonvertebral fractures. And strontium ranelate, despite its theoretically neat mixed action profile, has fallen completely out of modern favor.
Instead of looking backward, we must highlight the pharmacology of the future, a favorite area for academic examiners, by the way. Specifically, I am calling out the highly anticipated sclerostin inhibitor, romosozumab. This is a genuinely practice-changing biological agent that is poised to rewrite our treatment algorithms. Alongside it, keep a very close watch on odinakitib, a cathepsin inhibitor, and saracatinib, a tyrosine kinase inhibitor, as they move rapidly through the developmental pipeline. As we wrap up this comprehensive explainer, I want you to reflect on this overarching paradigm shift. Osteoporosis is not merely a loss of bone mass. It is a comprehensive, system-wide failure of trabecular microarchitecture and clinical bone strength, requiring definitive endocrine management. So I leave you with this. Does viewing osteoporosis as a complex, multi-system microarchitectural failure fundamentally change how aggressively you will screen, diagnose, and therapeutically manage your future patients? It absolutely should.